Welcome to A Shot in the Arm podcast. I'm your host, Ben Plumley, and this is a podcast about innovation and equity in global health. Well, we've got a double whammy for you in this particular episode. I'm joined by Dr Nduku Kilonzo, who is the chair of the UNAIDS Global HIV Prevention Coalition. She is the recent executive director of the Kenyan National AIDS Control Council, and she is also the founder of one of Africa's most effective healthcare policy think tanks, Yamaya Health Advisory. We're also going to be joined by Dr. We're also going to be joined by Dr. Thembisile Xulu, who is the Chief Executive Officer of SANAC, the South African National AIDS Council. I had the chance to speak to her earlier today on Zoom from Johannesburg, South Africa. But first up, let's meet Nduku Kilonzo. Nduku, welcome to A Shot in the Arm podcast.
Thank you very much, and I'm really honored to be here. I'm certainly happy to have been invited, and I've been looking forward to get the opportunity.
Well, this is the first of very many, and I'm looking forward to some earth-shattering conversations, not least this one. So here we are in Kigali at the International AIDS Society Scientific Conference. 2 days, I guess, no, 1 day into it. Mm-hmm. What have been the key findings, key learnings for you?
Wow, that wasn't part of the conversation, but I think the first one is that it feels as if a lot of the conversations we are having are going back to the earlier conversations before the money. And, a lot of what we left behind, the use of established systems and structures. We left behind, groups such as faith leaders, we left behind. So there were things we had before we had a lot of product, before we had many different interventions, before we had many different players, and before we had a lot of money. And we are kind of coming back full circle to them. I think this time, though, is that as we move forward, we have a lot of lessons that we have learned. Yeah, I think that to me is a reflection that I've been picking up on from the very many different kinds of conversations.
Well, it's the first conference in the post-money era, isn't it, really? But one of the things that you're here for is, I suppose, the rollout of a report produced by the HIV Leadership Forum on sustainability, a report that you all had written back in October last year. A group of directors general, of national AIDS programs. And before actually getting into the details of the report, because I think it is really groundbreaking, really important for the moment, just what is the HIV Leadership Forum?
It's simply a community of practice of director generals of national AIDS commissions from Africa, Asia, and Latin America, about 38 countries. And where this came from, the HIV Leadership Forum really started just as a community of practice, established under the Global Prevention Coalition. And this was back in about 2016-17 when we were really losing prevention. And there was a lot of action at the global level on advocacy, but needing to engage with the country level so that countries were then reinvesting back in HIV prevention. Because during the scale-up of ART, we seemed to be leaving prevention behind. And we were saying at country level that ART will push the button and will push the boundaries, but to be able to close the tap, really, of new preventions, we needed to be able to keep prevention interventions running. because you wouldn't, even when you get to 95, as we've all been moving in that direction, you'll always have undiagnosed people who are positive, those who were diagnosed and not on treatment, those who were on treatment and somewhere along the way fell. And that means there will always be new infections. So prevention was a priority. The forum then started to really, should I say, quote unquote, rescue prevention at the time. And the GPC then was involved in advocacy, and at the global level, we had the country scorecards, we had, all these things. The HIV Leadership Forum, as a community of practice, then was established by NAC Director Generals, and has evolved from just a community of practice to, what is considered a forum where DGs have conversations about not just prevention, but about the HIV response.
Which gets us really to this sustainability report. You all wrote it back in October 2024. It covers really quite systematically all aspects of the HIV response, from procurement of medicines, diagnostics, and other essential commodities, to stigma and discrimination campaigns, prevention, treatment, diagnosis, but also a lot of the organizational management that has gone into the AIDS response over the last 20 odd years when we had the big bucks. And it, to my mind, was preparing us for the days when we wouldn't have the big bucks. Even last year, we knew that there would be a transition coming. But is it fair to say that this is essentially a roadmap for countries on what to consider and on what to do? I certainly view it that way.
Thanks. And so, my role has been supporting the forum, and DG started to talk about sustainability at the time and saying, what is, as all the countries were starting to do sustainability plans, we were also asking ourselves at country level, beyond this sort of global level planning that was supported through UNAIDS, where are countries sitting? What do they feel are the priorities? Where do they feel the biggest challenges? And where countries sat was that the highest, biggest, largest vulnerability to sustainability was the architecture of the HIV response, with multiple, first of all, very vertical system. And let me start by acknowledging that it was essential and necessary to drive scale. A lot of the scale we did. But somewhere along the way, inadvertently, then there was establishment of parallel programs, parallel implementing points at country level, parallel data systems, parallel supply chain mechanisms. There was, human resources who were donor supported, employed through NGOs that were not compatible, or whose terms and conditions of employment were not compatible with national systems. And therefore, where we felt as DGs, as countries, where DGs were saying, this is where the biggest vulnerability is. And should resources stop, these systems will likely collapse. And if they collapse, these are the systems that drive services, the systems that drive interventions. They are the systems that drive the data and surveillance and monitoring that we have. These are the systems that drive commodity security, because they are the supply chain. These are the systems that drive, even political will, because it's the numbers that then, are used for information and so on. And those were all funded with the resources that were in plenty and available. And because the conversations about transition and recognizing that transition was going to come were already happening, DGs then sat down and looked at where the largest vulnerabilities are. Now, post, segueing into post-January, when the resources, generally were shut off and no longer available for the HIV response. DGs then sat back and said, look, we recognize, because the reality is that anything that was not anchored on government systems fractured instantaneously. It was there today, tomorrow it wasn't there. Data systems, let's say for HIV prevention particularly, that were run through NGOs, communities, networks of persons living with HIV, and, through a PEPFAR-supported system, suddenly that data was no longer available. And so even today, as we talk about surveillance and thinking about reduction of new infections, other than modeling whose data, I'm not sure the source, we're going to have a challenge.
See, this is one of the things I'm really astounded by. And I've been working in this field, we've both been working in this field for the longest time, certainly before the money arrived and then after the money arrived. And it's extraordinary, isn't it, that we have let this happen, that the reliance on one donor, essentially, has made us so profoundly unable to take the reins immediately the funding comes to an end. Now, it might be argued that if we had a year's notice or 18 months notice, things would be very different. But those parallel structures are the things that really surprise me. And one thing I'd really love to get your thoughts on, Nduku, are, this question, and we've heard it so many times here in Kigali, that, we have a parallel system of NGO implementation that is largely funded by donors, to date, mostly the US, and that implementation has been very, very expensive and not really compatible with the kind of program services, particularly in HR costs, that happen by countries themselves. And I think one of the confusing elements, and I don't know what you think about this, is that in our mind's eye, we are conflating international NGOs with local community organizations and thinking that the two are the same, so that an FHI in Kenya has the resources, pays the salaries in very different ways than, say, the network of people living with HIV in Kenya. Has that materialized in your conversations?
Obviously. I mean, the financing funding architecture being very largely Western NGO driven, and that money then was cascaded down to community-based organizations. I think the bigger question on the table, and really this is where the moving forward question comes in, is, okay, we had all these systems that simply were there, the next day they were not there. We have a lot of trying to recoup some of them back. We have, let me give examples. You have, if you think the data systems, you had, let's say, facilities that were supported by electronic medical record systems that were NGO supported. So different facilities in different countries, especially those countries that don't have a central HMIS system, have different EMRs. Those different EMRs are run by staff, even if they're located in a public facility, are run by staff that are NGO supported. And they also report to a mechanism that is run by one of these large NGOs supported by PEPFAR. So what you then end up with is that when the stop work order came, suddenly you have facilities shutting down. And when they shut down, the data also shuts down. So, there were instances where patients or people living with HIV transferred without data, and yet this transferred to the facility without data. And yet we are talking about longitudinal care, chronic care. So that's problematic. And that is not to say there wasn't value in having those resources. It is to say that the lessons that we must learn moving forward is that any investments must really look at, should the day these dollars are not available, does this system still stand to support the service delivery? And if the answer to that question is no, we can call that a project that is dependent on that resource and not call it a program for the country.
Right. But it begs the question as well, whether if the money goes away, it is fit for purpose.
I guess so, yes. It does. And I think that the way of thinking through that is also asking ourselves, the dollars that we had, could we have used them better to be able to get much more done? Because where we are also is that, for instance, if you think about prevention or treatment, the influx, so governments adapted immediately, as would be the case. They pivoted and repurposed programs from being, people living with HIV, moving them either to outpatient clinics or to chronic care clinics. Now, this was done in the context where human resources just significantly dropped in most countries. It was done in the resource where laboratory systems and platforms have just kind of like the human resource running those as it stopped working. It was done in the context where you already have the existing nationally funded healthcare workers already having a full, plate, whether it is NCDs, whether it is mental health, whether they have a full plate. So HIV then became additional, but it was never really integrated. They may not have had all the training skills. They now have additional patient load with less human resources. So the quality of care is also going to be affected by the way in which we designed our previous programs. So as we think about moving forward and fit for purpose, we must ask ourselves, should the dollar not be there, what will be the implication for persons living with HIV? What will be the implications for those who are at risk of HIV infection? Because we have to think there's the dollar aspect, there is the human aspect, and then there is the fact that systems are simply gone. You have a bit of a challenge about how you move forward.
Well, you mentioned the different country experiences, and as I said at the start, I had a chance to speak to our good friend, Dr Thembisile Xulu, who is the CEO of the South Africa National AIDS Council. Why don't we just take a listen and a watch about what she said? So, Dr. Thembi, welcome to A Shot in the Arm podcast. Where are we catching you from today? Where are you exactly in South Africa?
Thank you so much, Ben. I am in Johannesburg, very freezing Johannesburg, South Africa this afternoon. Thank you.
Well, greetings from a very balmy Kigali. Now, we're talking about the HIV Leadership Forum, and you all had written it back in October last year. And yet it feels very prophetic, very prescient given the circumstances. When you wrote it, and when the Directors General of the National AIDS Commissions from around the world came together, did you have in your mind that it might be something that could have very immediate applicability?
Thank you so much, Ben. So I think when we looked at the future in terms of where the world was going financially, we could see that, even the donors that fund the HIV response were starting to tighten their belts, and countries needed to think differently. It was clear to us that what the bigger donors, the likes of the US, had been putting towards the AIDS response would not be the same. And donors that are in Europe, for instance, had other concerns, whether it was war, or climate change. There were other pressing issues for the world, and HIV was no longer a poster child for foreign aid, if I can just put it like that. So we said it was important for us as NAC directors to lead the sustainability discussion in a way that would set up countries to succeed, because we are normally placed at the apex in terms of multi-sector coordination at country level. And we are really the accountable structure for how a country is able to hold itself accountable for the HIV response, including not only what comes from the domestic financing, but also holding donors accountable. And we thought it best to say, let the sustainability agenda be driven by us who understand the countries more. So that is where we were coming from.
And in a sense, who else can drive the sustainability agenda but the leadership of heavily affected countries? It's so important, and we're so grateful to you for giving us time today to look at the South African example, both in terms of what you have done, but also what guidance the country can provide to other countries, both Pan-African, but indeed in other parts of the world. And I suppose this is a question for the last 6 months that has come at you on a very regular basis. But how is SANAC, how is South Africa coping? The sudden jolt in loss of particularly US funding has had a major impact around the world. How are you guys coping, and what have you done to address and overcome it?
So, Ben, I think in South Africa, we have been fortunate in that the bulk of the HIV program, being 77% to be accurate, is funded from the national fiscus. So National Treasury actually funds that program. We then have about 17%, which came from the US, the United States, PEPFAR, and then about 6% from the Global Fund, and another 2% coming from the likes of the private sector. So the 17%, as much as it might sound small, was a shock to the system. But I think we were much better placed compared to other African countries that rely much more heavily on donor funding. So what we were able to do was to quickly gather evidence in terms of utilizing the data, because PEPFAR was supporting 27 high-burden districts. And we then had to use that data to say, how do we then reprioritize and reimagine the delivery of HIV programs when the NGO-run projects that were supported by PEPFAR are no longer funded? And that meant within the conditional grant, which is provided by government, a plan had to be made to say these NGO clinics that were run by PEPFAR run on parallel systems, not just for data, but for lab, for procurement. How do we start moving those into the national system in order to ensure sustainability? And a simple example, Ben, as the partners that were running clinics for key populations, for instance, outside government facilities, transferred some of their files to public health facilities. Clients were informed in terms of where to get access to treatment. And one of the promises that the minister made, even when we issued a circular to all 9 provinces, was that no patient should be without treatment. So there really has been a plan to say a lot of patients that were getting prevention and treatment services in facilities that were run by NGOs, funded by donors, have now been slowly shifted into the public sector. But the truth of the matter, Ben, is that not all clients, particularly key populations, are comfortable with accessing services within the public sector. So it was now an issue of social contracting and making sure that community delivery by peers continues, and that is supported by the likes of Global Fund in South Africa, but also by the likes of the government. So we've continued with social contracting to make sure that services that offer one-stop shops for our key and priority populations continue, and that the HIV program does not collapse. So the fact that there is political will to make sure that the general population continues to access services, but that key populations also get access to services, and we beef up on how we provide prevention services at both public as well as NGO and private facilities, has really been part of the overall mobilization of how we are reimagining the architecture. We are certainly better placed, as I said, financially, because in the budget speech last week, the minister also released a statement informing us that Treasury has actually released more funds to support the HIV program. So really, South Africa has been at the forefront in terms of utilizing the data to understand our epidemic, making sure nobody runs out of treatment, but more than anything, involving communities and making sure that the systems that were being run by our PEPFAR partners, etc., are now being reintegrated into the national systems for a sustainability, from a sustainability perspective.
You see, it's so interesting because you have captured there both the challenges that the sustainability report highlighted, but listed very effectively how South Africa is addressing them. I think one of the key surprises that comes out of the report is that this creation and maintenance of parallel structures over the course of the last number of years in the AIDS response, that donors, particularly the United States, would have its own reporting mechanisms, its own procurement mechanisms, and indeed its own services funded largely through NGOs. And of course, there's a question about salaries and integration of benefits for workers who are in the non-profit sector, which in many ways, bizarrely, is actually, if I may say, in many settings, a sort of a better gig, if you like, than if you were in the within the national system. But why do you think people on the outside would be so surprised that there was such, I don't want to say decentralization, but yes, the parallelization of services? And I guess how difficult has that been over the last few years for you to manage, particularly as you look at how you meet your 90-90-90 targets, and indeed how you meet your own domestic ambitions and needs?
Okay, so I think donors really, Ben, have come in to countries with delivery mechanisms and funding architectures that really have not been compatible with government-managed services. And as much as a country would sign a country operational plan, the so-called COP, once the US government would start doing work in provinces and districts, they would then sign individual agreements with the NGOs that they fund. So government would not essentially have sight of what happens within those particular NGOs. And what you end up finding is that we do have these multiple NGOs that are chasing certain targets that are set by their funders, not necessarily aligned to national priorities. We don't know what is in their contracts, but what we do know is that the funding was not aligned, for instance, to the medium-term expenditure framework. Their costs, came in at really very, very top-heavy employment structures. And we found that they had also high negotiated indirect cost rates. And even when you compared the salary or the organograms and the staff that they had, there is nothing comparable within the Department of Public Service and Administration. Now, because they worked, as I said, in high-burden districts, their help was needed. They contributed to putting more people on treatment. South Africa currently has the highest absolute number of people living with HIV in the world, an estimated 7.8 million. So at the time that they were working, they did have parallel systems, as I said, in terms of data, in terms of human resources, supply chain, commodities, etc. And we found that even when we looked at the prevention projects that they were doing, it wasn't aligned with the national system in terms of providing an overall responsive prevention system for the country. And we then were really, taken by full surprise when we got to the point when the executive orders were issued, because when they gave us these costs and we tried to compare, if the country had to take these over, nobody in the world, Ben, could ever try to match what PEPFAR put into the system. So we are really now trying to make it work within the current fiscus. And we are realizing that really the limited investments that have been made, especially by other African countries, really need to be utilized in a way that stretches, each dollar or each rand more, but also that the donors that remain actually need to be managed in a framework that is mutually accountable, where it's not just the fact that a donor is bringing money to assist you with your burden of disease. At the same time, you want to be having a conversation with the global health initiatives, the likes of Gavi, Global Fund, GFF, to say, are you aligned with national priorities? Do you understand what our country needs are? Are you then helping to invest in resilient and sustainable health systems so that our sustainability model is one that boosts the country to be able to withstand further shocks like we had during the time of COVID?
So if I may pick up on two elements that you commented about. The first is in relation to donors. You've begun to use language that I think really changes the dynamic between what we used to call partner countries and donor countries. But essentially that if countries want to be supporting national aid strategies, national health strategies more broadly perhaps, there are things that they need to do to adapt and mold themselves to fit your priorities rather than the other way around. How are you finding conversations with donors as you build this new, as it were, this new paradigm of engagement with the different sectors?
Yeah, thanks, Ben. I think there's no doubt that there is a requirement for change on both sides, because the countries have to be set up to succeed, which means our global health initiatives really have to share with us a common understanding in terms of what sustainability means. So we are really, I would say, starting to enjoy a place where not only heads of state, but where African ministers of health, but also technocrats like ourselves as national AIDS DGs in country are able to speak to country-centric sustainable planning models together with our global health investments. We have been able to define, for instance, the Lusaka agenda that speaks to how do you align the agendas as well as, for instance, the reporting and the architecture of the global health initiatives to make sure that they fit in with what the countries have in terms of our own medium-term expenditure framework. We have started, I would say, really as the African continent, because I sit on the Global Fund board as the focal point for Eastern and Central Africa. And Africa commands the largest share of investments from all the major global health initiatives. And yet, despite this significant footprint, the representation remains fragmented across the different boards in terms of the Gavi, Global Fund, GFF. And we are saying, whilst the donor constituencies normally take time to position themselves in terms of coherence, African voices are more often very reactive rather than being proactive. And in defining, for instance, the Lusaka agenda, we have rapidly been evolving to find a common African collective leadership under the ministers of health that are leading the African agenda, as well as a coordinated and coherent representation in terms of all the global health initiatives.
And honestly, I think that leadership is much needed, and it's wonderful that it is, flourishing now, particularly now. The other thing that you commented on briefly was around integration, and perhaps South Africa is in a unique situation given the numbers of people living with HIV, the numbers of people on treatment who are HIV positive. But for many countries, the need to not only incorporate donor-driven NGO programs into national aid strategies, but to align national aid strategies with overall health strategies. That is something that has been a central plank of the HIV Leadership Forum Sustainability Report. And I just wanted to get your comments on how you see both South Africa and countries pushing that broader integration agenda, where it makes sense and where it doesn't make sense.
Thanks so much, Ben. So I think it makes sense overall from everybody's perspective. Last week, UNAIDS released the Global AIDS report for 2025. And it's really a mixed bag. You can see that the world has been doing well in terms of the reduction on new infections, as well as more people on treatment, reduction in mortality. But there is a fair number of countries where new HIV infections are on the rise, the likes of Middle East and North Africa. And we are saying with HIV no longer being heavily invested, let us take the investments that we put into HIV and use those to strengthen the health system overall. And integration from our end essentially means that this is the pathway that we are taking towards universal health care to make sure that our patients are able to access, a service delivery for HIV, for TB. Our HIV patients have grown older. They now have hypertension. They've got diabetes and other chronic conditions. So let's allow them to be able to get access to a one-stop shop. But more than anything, rather than having multiple non-interoperable data systems, let us make sure that we've got unified HIV data systems that are compatible with central national systems. Same for lab, in terms of making sure that we are aligned with the Ministry of Health's lab systems. And even from a human resource perspective, rather than have a situation in a clinic or a hospital where there is a primary healthcare side, then there's an HIV side, then there's a TB clinic. We are saying we are providing comprehensive services for all patients so that our patients are able to access services at a one-stop shop. And this applies not only to the public sector, but also to the NGO sector, particularly the ones that cater for key populations who are still experiencing stigma and discrimination and might not be comfortable with coming through to government services.
Well, I think, again, South Africa plays a really important model for how the countries across the continent and abroad are going to build the kind of programs that the sustainability report is looking for, or the enshrinement of the values and the core components. Thank you so much for giving us time today to look at how South Africa has responded. And I know Yvette will slap me if I don't ask this. But it would be wonderful if we could come back to you later in the year to see how you're doing and, again, what lessons could be applied more broadly around the world. So, Dr. Thembi, thank you so much indeed for your time today.
Thank you so much, Ben. Yeah, I must say you are reminding me with the mention of Yvette that I think I highlighted earlier that one of the key areas that South Africa has really been pulling its weight on is the issue of involving communities and social contracting. And our model is one that can be used to teach the world how to give communities meaningful involvement in the HIV response, not just in terms of advocacy, but in terms of service provision, as well as bolstering HIV prevention, care and treatment programs.
You know, I'm not going to let you go as a result of that, because as well as the community leadership, South Africa, of course, and you mentioned this, has been at the forefront of engaging partnerships with the private sector. And of course, my history is in setting up the Global Business Coalition on HIV and AIDS back in the early 2000s. And again, we look to South Africa as really the model of the kind of integrated private sector support, particularly to prevention, but also testing and treatment services. So it would also be wonderful to come back later in the year and just find out how that work is going as well.
Absolutely. And we would be more than happy to share, because with the executive orders that were issued recently, we are reinvigorating the funding model by the private sector, which was the Solidarity Fund, in order to see how the private sector can help to plug the gap that was left by PEPFAR. But more than anything, how they can help to invest in resilient and sustainable health systems moving forward. And SANAC has just institutionalized a SANAC Private Sector Forum, and we'll be happy to share how making sure that the private sector works with government and communities really makes an HIV program succeed when it is multi-sectoral in terms of its response. Thanks, Ben.
Super. Well, thank you very much for that offer, which we will be delighted to accept. I know I've taken up a lot of your time. We'll let you get back to doing the Lord's work. Thank you so much for your time today, Dr. Thembi.
Thank you. Thank you.
So, Nduku, I mean, Thembi can speak for all of us. You sort of feel there's nothing further that needs to be said. But, you know, a couple of reflections, it would be really good to get your thoughts on what she said. I was really struck by what this actually means for the relationship between countries and international funders and international implementers. And again, it's something that really underpins the HLF sustainability report, that although we spoke about initiatives like the 3 1s, the UNAIDS initiative that recognized country leadership, in practice, we sort of really didn't. If you were to receive the largesse of either a private sector, but more realistically a multilateral or a bilateral governmental donor, you had to do things the way they wanted. And those days are gone. That's all shifted now that the money isn't there anymore. So how does a Director General of a National AIDS program reporting either into the President's office or into the Ministry of Health, how do they change the narrative, change the relationship with donors who may still want the same kind of unique, parallel reporting and accountability mechanisms that they were used to?
So I think for this question, I'm going to kind of reflect on my own past as a Director General or a CEO of the National Control Council of Kenya. And I want to start by highlighting that we are seeing a narrative that seems to suggest a lack of agency by governments. Yet, immediately there was a withdrawal. The first thing was a pivoting by governments to ensure that, treatment was maintained. It has resulted in some of these challenges that I have talked about. But those are implementation, operational challenges that are about, the situation everyone found themselves in. So governments are not helpless, and governments are not sitting and waiting for, populations and their populations to die, and governments are not working to fail. Having said that, it is to recognize that we have to shift the narrative in a way where we rethink and reorient the partnership agreements so that we actually start to have partnership agreements. Agreements where, and I think this has been more underpinned much more now by starting to have bilateral conversations as opposed to a very one-size-fits-all approach to health, or the HIV framework specifically, that is non-negotiable and is very driven by the resources. The other thing I think we need to recognize is that there are different countries are different. We don't have a single, there's no homogeneity, so to speak, across countries. So we have countries that have more resources. We have countries that have more advanced health systems. We have countries that have less poorer health systems. And so the question on the table is, what do we understand about your country's systems, or the country systems that anyone wants to put and support resources into? And with that understanding of the country systems, how are you leveraging, or how are you using that information to build fit-for-purpose programs? Because I think that a country that has more resources will adapt its programming, its prioritization approach, its investment options in a very, very different way from a country with less resources. The overarching bottom line, I think, is going back to where we started, which was we started off with a multi-country response, where we said, okay, we have social health systems that transverse the country. We have youth systems in almost every country that transverses the country. How do we work with the youth departments or youth ministries directly to deliver HIV self-care for prevention? Because that is the most effective, efficient way to reach the highest number of young people, rather than trying to build a whole new parallel system to reach many young people.
Yeah.
So for me, I think that's where the fit for purpose there, how you redesign the relationships coming. We must go back to a multi-sector response, because there are no other systems to work with.
Yeah. So I realize we're coming up to the top of the hour. Just quickly, we'll put in the show notes the link to the sustainability report in a number of languages. What happens next with it? What is the HILF going to be doing next in terms of supporting countries?
So with the position paper, actually the Leadership Forum called it the position paper. Sort of leveraging country leadership for transition. That was in October last year. So when there was the stop work order in January 2025, I think all director generals or CEOs of AIDS commissions are government employees. They understand what an executive order means. An executive order is not negotiable. It is a presidential order given within the context of law. And so immediately afterwards, there was a meeting, and this meeting was held on the 30th of January. And the first thing DG said is, can we do a country transition readiness assessment that identifies, one, the pain points countries are going to have to deal with, that identifies where the opportunities are, and that identifies, sort of where are the investment opportunities. And That report is ready. Actually, it will be presented this afternoon at the IAS. But importantly is that the next thing is how we are leveraging that response at country level. And the Leadership Forum really will continue to, one, support countries to think through what their challenges are, their prioritization processes, with specific regard to prevention. It is rethink prevention, because right now countries really do not have very little to go on for prevention.
Yeah.
And NACS will be at the forefront of ensuring coordination across multiple sectors for
And
delivery.
NAC here, National AIDS Control Commissions.
Yes. Sorry, acronyms. We still can't get over them.
I know. Bane of our lives, right?
Yes.
Well, I'm really looking forward to being on this journey with you as we see how countries evolve their AIDS response. I want to throw one difficult question at you as we wrap up, because I know you'll let me do this. So, Dr. Nduku Kilonzo, will we end AIDS as a public health crisis by 2030?
Well, first, I love the term that you have gone back to calling me Dr. Nduku Kilonzo. I take that question very seriously. I don't think there's a definitive answer. I think there are very many dependent on. But most of all, as we must acknowledge the fact that government is responsible and is the leader of the HIV response in country. And with that, if we start to work through national systems, country existing mechanisms, and that includes mechanisms that are not necessarily government, faith-based facilities, faith leaders, mechanisms that are in the private sector. Once we recognize that countries are not vacuums to bring new systems into, and there are systems that we can model around and work with, I think we will be on track towards really getting to 2030. The other piece is reorienting partnerships and relationships. Reorienting means that the external resources that are available through partners must recognize these existing systems. They must recognize the existing partners in country and work through those. The systems that are, the partnerships that are within country need to be sitting back at the table where we have networks, government, communities, the private sector. I started by saying the multi-sector response. We're going back to the beginning. Thank you.
Thank you. Well, you choose your words very, very carefully, and I urge everyone to listen and indeed watch and absorb those indeed very, very carefully. So, Nduku, thank you very much. Thank you for being on A Shot in the Arm podcast.
And thank you very much for inviting me, and I look forward to further engagement. Thank you.
Well, that's it for this episode. Thanks again to Nduku. Thanks also to the production team here in Kigali, Rwanda, with Eric Espera, our director and producer. And finally, a big thanks to you. Now, don't forget to subscribe and give us 5 stars wherever you download your audio podcasts. And of course, visit us on our YouTube channel at youtube.com/@ShotArmPodcast. Like, subscribe, and smash that notification button so that you can be given the heads up on all of our latest content. Well, with that, have a great day and a safe day, everybody.